Our first really good, strong medical session is really looking at 20 years of treatment. Like, where were we, and now where are we going? Because think about this. When John Qualley was diagnosed in 2000, remember, Beacon was started in 2005. He was living with bladder cancer, especially with upper tract disease, from the very beginning. There was no organization. And they decided it was important to have an organization. And bladder cancer was treated with surgery with the urologist, and they could take your bladder out. There was BCG. This is 20 years ago. And if it became muscle invasive, they took out your bladder, and that was it. If it was advanced, they gave you chemotherapy. That was the option that was available. Mm-hmm. They didn't really do much in the radiation space 20 years ago. And so we've really evolved over time. It's never a good time to have a cancer diagnosis. But this is a much better time to have a bladder cancer diagnosis than it was 5 years ago, 10 years ago, 15 years ago, or 20 years ago. So I'm really, really delighted to bring together urologist Jennifer Linehan, and she is at St. John's Cancer Center in Santa Monica. And Dr. Brent Rose is second to speak, and he's a radiation oncologist here at UCSD. And then Dr. Tyler Stewart is on the end. He is a medical oncologist. We've been talking to them about really kind of covering what happened in the past and how are we looking forward to. I hope that you feel excited and invigorated because of all that's going on in the bladder cancer space, because of our pharma partners, people with metastatic disease, where they don't respond to chemotherapy, are not just told to get their affairs in order. They're told that we have options. They never had them before. And I hope it makes you feel better that you can offer those. And
never a good time to have cancer,
yeah.
But it's a better time today than ever before, and looking forward to bringing more options in the future too.
Yeah. So we're going to start with Dr. Linehan, and then we'll just kind of go down the row, and then we'll open it up for questions. So if you have questions that you're thinking of right now, we gave you a notebook for a reason. Write that question down, so when we go to the Q&A session at the end of the presentations, you'll remember what it was that you were trying to ask about, okay? Okay. Dr. Linehan.
Thank you. Hi, I'm Jen Linehan. I'm a urologic oncologist in Santa Monica.
And you can walk around if you want to.
Huh? I can walk around?
Yeah.
Okay.
Yeah.
I'm sorry, I'm a mover, I gotta walk. So let me tell you a little bit how I got involved in Beacon. So Beacon has this meeting called the Bladder Cancer Think Tank. And anyone who was anyone in bladder cancer, and I'm talking doctors, was at that meeting. And it was an invite meeting only. And these were really sort of the world's experts on bladder cancer. And they literally put them in a room and said, what's new, what's good, what's out there, how can you all work together to advance the field? And I wiggled my way into this meeting. I think I literally showed up outside the meeting and said, I want to go to the meeting. She was like, all right, go to the meeting. Because I wanted to know what the latest research was, because they were just really in the thick of it. So that's how I got involved in Beacon. And so here I am, a urologist. I'm not trying to get into my national AUA meeting. I'm trying to get into an organization meeting for patients. And when I saw what was happening with Beacon, I really sort of fell in love and was hoping to work with them more and bring patients. And then when I give patients their website, it really is an incredible organization. And then Diane came out to visit me once in Santa Monica. And I am a robotically trained surgeon. All I'm supposed to do is surgery. And she told me her husband's story about bladder sparing, kidney sparing, immunotherapy and chemotherapy and radiation. And I was like, wait a minute, you mean I don't have to cut it out? That's amazing. And so then I even got more involved in bladder sparing technologies and the things that we could do to advance the field, because that wasn't things that we talked about ever. We didn't even talk about, when I started training, giving chemotherapy prior to taking out your bladder. There was just none of that. So This is an incredible organization. I'm really grateful to all of you sitting in the audience. Every day I talk to patients, but I don't often get to teach them, so this is a great opportunity. I'm gonna roll you through an actual patient case that I had, and it's gonna help kind of elaborate on all of the options for non-muscle invasive bladder cancer. And oh my gosh, there are so many now, it is hard to keep it all straight. One of the things I spend a lot of time doing is called trial navigation. When I was in my residency, if somebody said, I'm gonna put you on a clinical trial, that meant things weren't going well. That was your last hope. Bladder cancer, non-muscle invasive, that is not true at all. Some of these trials outperform our tried and tested treatments. So I spend a lot of time figuring out where I can send the patients, even if they need to go to other places, so that they can get the best treatment, because there's a lot of trials. And if you have one treatment in this trial, then you may not be a candidate for the other trial. So I got to figure out how aggressive is their cancer, figure out what trial they need to, or do they just need the tried and true treatment. So I'm going to kind of walk you down that pathway a little bit today, and hopefully that kind of will bring to light all the opportunities for non-muscle invasive patients that are out there. So this is my really sweet patient, Rosemary. She is 59 years old. She's a single mom. She works in the office of a vascular surgeon. She had bloody urine for 3 months. They got a CAT scan, and they saw a small tumor in the bladder. And I know many of you, this is your story, right? So of course, you come in, you get your cystoscopy, we look in the bladder, there's a tumor. And what am I first thinking? Okay, I'm thinking, hopefully this is non-muscle invasive. 70% of those tumors are. 70% are TA, which is just at the very surface of the bladder. 20% are a little deeper, T1. And 10% are CIS. CIS is carcinoma in situ. Even today, in all other specialties, carcinoma in situ is considered a lesser cancer. It's less aggressive, it's considered just very on the surface. CIS or carcinoma in bladder cancer is a very different bird. It can be more aggressive than high grade or localized cancers or very surface cancers. So, and about 10% of the non-muscle invasive are CIS. So, before she saw me, she had a urologist in her local town. He did a tumor resection, he cut it out, and he put a beam, which is a chemotherapy, in her bladder at the time he took it out. This is standard of care. It really helps prevent the time to recurrence. That's why we do it. I tell patients, there might be some cells sloshing around in there after I cut it out. We're gonna put this in, you're gonna hold it for an hour, and we'll take it out, before you go home. Her pathology came back T1, so not at the surface, just a little bit deeper into the bladder, but high grade, and she also had CIS. CIS is very difficult for us to see. It is not something I see well. There are some technologies called blue light that help me see it better. Blue light is a dye that you put into the bladder, and when I put the camera in, the dye lights up the carcinoma in situ, so I can see things that are smaller and see things that are better. But it's very hard for us to see sometimes. Most of the time, I diagnose CIS because of the bladder washes, just a urine sample, okay? So this was her pathology. So let's talk a little bit about tumor biology, and I'm going to try to keep it really straightforward. There is high grade and low grade. Those are our two options. Low grade, I tell patients, it's like an annoying weed. There's a very high recurrence rate. It's going to come back. It's not going to kill you, but it's going to be annoying. And that's about 50 to 70% of recurrence rates. 5% of those cancers progress. It's really rare that those patients progress. I have to be honest, in 20 years of my career, I don't think I've ever seen a low-grade patient progress. High-grade patients, these are tumors that are at the surface. They're not muscle invasive, just like we keep talking about, and carcinoma in situ. Carcinoma in situ, like I said, in all other cancers is a lesser cancer. In bladder cancer, it is high grade and can be aggressive. The recurrence in these situations is sometimes over 80%, and 50% of them will progress. What does progress mean? Progress means increasing in the number of tumors in your bladder. Progressing also means it goes into the muscle wall of the bladder. So there's the inner layer of the bladder, then there's a second layer, then there's the muscle, then there's the fat. It gets to the muscle, we're talking about chemotherapy and cystectomy or radiation and cystectomy, which is bladder sparing. And these guys are going to talk about that right there. They're way more entertaining and probably way more knowledgeable about that. So there's low grade and high grade. She has high grade. So her recurrence rates are high and has a high progression. Now, one of the things that is always tricky for doctors in bladder cancer, there's always this gradient of how cancer is going to act. You have some high-grade cancers that are actually not going to be that aggressive, and you can just cut them out, leave them alone, and have the patient come back in 3 months and put a camera in. You have high-grade cancers that are going to act very, very aggressive. For me, I use what's called the International Bladder Cancer Group criteria. If something is high grade, if anything is high grade, if it's CIS, I'm automatically considering it very aggressive. For patients with low grade tumors, these are usually low risk. They still can recur, they're just not likely to progress unless they have any of those features I told you there. So if they're over 3 centimeters, if there's multiple tumors in the bladder, if there's early recurrence, frequent recurrence, or failure of intravesical treatment, that's that washes that we put in the bladder to treat your cancer. If any of those criteria are there, I'm going to consider them that they might be more high grade. I'm going to treat them like high grade, and that's the big difference. Because low grade patients aren't going to get bladder washes, they're going to get their tumor cut out, and they're going to see me in 3 months to see if anything's come back. High grade patients are always going to get some follow-up adjuvant treatment. Adjuvant means after surgery, after we've done something else. Okay? And that is the intravesical therapies. So let's move on with her story. So she got gemcitabine, which is again a chemotherapy. She got six doses, 6 for 6 weeks. So we usually give it once a week for 6 weeks. It's kind of the standard of care. That data does come from somewhere, but we've all kind of adopted it. That technically in this situation is not the first line therapy. Okay, but again, this is kind of before she got to me. But she got the gemcitabine by itself alone for 6 weeks. She comes back to the office, she gets another cystoscopy, there's still tumor there, and more tumors. They repeat the biopsy, she's still T1 high grade, and her cytology is high grade, which to me says there's still some CIS swimming around in there. That's what that's saying. She then gets a treatment called mitomycin. This is another chemotherapy. Now, this actually has some very good data on it, and he could have probably used it as his first-line therapy in this situation. Again, into the bladder, once a week for 6 weeks, she gets all 6 treatments. Okay, so now this is her second therapy going into her bladder that she's gone through, okay? Mitomycin actually has about an 80%, I would say, complete response rate. Not a cure rate, complete response. There's still a chance that the cancer can come back, but after you get the 6 doses, I look back in, there's nothing there. That's what we would consider a complete response. How long a treatment holds that complete response is the bigger issue, right? Is it going to be a year? Is it going to be 2 years? How long? So for mitomycin, it's actually some decent data that says 80% of the time for at least 2 years, the patients won't recur, which is pretty good. I'll take that. That means they're not coming back to see me to get their tumors cut out of their bladder all the time, and they're not progressing. A lot of the times these tumors are annoying, not life-threatening. But she comes back, she gets her cystoscopy, she has a 2-centimeter tumor on her bladder wall. She's now gone through 2 treatments with the bladder washes. Go back in, she also still has CIS. At this point in time, she finally gets to me and I'm like, okay, you really need BCG because this is our tried and true. We probably should have done this in the first place. So we give her the BCG, she gets 6 out of the 6 treatments, and that's actually very important. It's important to know how many treatments they get and how much they go through, right? Because if you don't get through all the treatments, that also makes a difference. What happens after she gets her BCG? I look back in, there's still cancer there. I try to give her another course of BCG. The first course is called your induction. You can do another 6-week course. So I'm like, okay, maybe it just wasn't long enough for the BCG to hype up the body's immune system and kill the cancer. She gets another course. She fails again. She's 59. She doesn't want her bladder removed. She's a single mom. She has to work. She's trying to take care of her kids. So I am doing everything in my power not to take her bladder out. She then goes through another chemotherapy set called gemcitabine and docetaxel, or gemdosi as we call it. That's our short. She fails this treatment. I then give her Pembro. Well, actually, my medical oncologist gave her Pembro. She fails Pembro. And now she's on nadofaragene. She goes through 2 doses of nadofaragene, starts bleeding again. I look back in, more tumors. I am sort of out of options at that point. I mean, there are other trials for her, but at what point, and this is a big question in urology, with all of the different bladder washes we have, at what point am I supposed to call it and say, listen, you have cancer that's blowing through every treatment we have, maybe we just need to take your bladder out. By doing these treatments, am I going to prolong her cancer to getting worse? These are things we all have to figure out. And this is one of the biggest questions that we have right now. So she went through 6 types of bladder washes. It didn't work. I finally sat down with her. I said, look, you're 59, you've got kids, this is not responding. We really do need to actually think about taking out your bladder. So we did a radical cystectomy, and now more than ever, we are focused on doing nerve sparing, especially for women, and vaginal sparing, especially for women, with a neobladder, which is where we take the bowel and we make a new bladder and hook it up to the P channel. So luckily for us, she had T1 high grade, she still had CIS, we took out 47 lymph nodes, and all her margins and lymph nodes were negative. So she sort of made it through that treatment. Now, we're gonna talk about muscle-invasive bladder cancer, which is a little different, and when these guys talk about that cancer, you generally get chemotherapy first before you get your bladder removed. Remember, this is not muscle invasive. This was a non-muscle invasive patient, and it's not really on the agenda to give the neoadjuvant chemo in this situation. So if you've had your bladder out and you're sitting in the audience being like, why didn't you get any chemo? That's why. So I also want to explain a little bit about BCG. So BCG, 30 to 50% of the patients who get it as a treatment will fail to respond. 10 to 15% of those patients will progress to muscle-invasive disease. Mitomycin failures, remember I talked a little bit about mitomycin. So RFS means recurrence-free survival, which again is important, like how long are they gonna live without getting more bladder cancer tumors? So for 1 year, 2 years, and 5 years after putting mitomycin in your bladder, it's 84%, 75%, and 51%. And patients, I have found out, do like to hear these numbers. That's why they come see us, because they want to know the odds, right? And all this is playing the odds game with all of the different treatments. So for mitomycin 2-year recurrence-free survival, it's better if you give a higher dose. It's 76% if you give 40 versus 66% for 30. So the dose makes a difference in this case. What about BCG resistant or unresponsive? So on this graph, is there a pointer on here? Okay, so on this chart, and I'm trying to not be crazy scientific about it all, there's Pembro, Venesium, which is a new treatment that's out, nadofaragene, which is alcyladrin, gemdosi, which is what I talked about, and something else called N803. These are all approved treatments, intravesical, for non-muscle invasive bladder cancer. This is a great chart by a doctor named Max Cates, and he's at Memorial Sloan Kettering, and he's done a lot of research on BCG versus gemdosi and all the different kind of comparing the different treatment options that we have. And you can see the 3-month, 12-month, and 12-month complete response. These are the numbers that they've put here of the different treatments. So for Pembro, it's only about 41%. For Venesium, it's about 40%. For Nadofaragene, it's about 53%. For Gemdosi, it's 60%, but that's out to a year. And N803, which is a compound that we use in combination with BCG, is about 71%. So those are all of the numbers that say if I give this to you, how well is that going to make the bladder cancer go away? And then again, the secondary thing that we're worried about is how long is that going to happen? Now that I've made it go away, is that going to be for 2 years? Is that going to be for 5 years? How long can we keep it gone? So these are some of the other treatments that are out there. This is a very cool graph, and the only reason I put this up here because it helps me figure out, where all the different treatments are. So you have chemotherapy, which is what we talked about, and chemotherapy basically kills the cells, right? You have immunotherapy, different immunotherapies you can put in the bladder, which basically hype up your immune system to kill the cancer. We have viral vectors, which is where we take viruses that are dead. We put things in the virus to go into the cancer cells and help kill them in different ways, and also create an immune response. So there's viral vectors, there's immunotherapies, there's chemotherapies, and then there are some novel ways to get all of these different medicines into the bladder. One is the pretzel. It literally looks like a little pretzel. We put it in the bladder, it's filled with chemotherapy. And it sits in there for a week, and then you take it out, and you do that again. They actually did a trial with this for muscle invasive bladder cancer too, except they did the pretzel with radiation. There's also a gel that you can put in the bladder called UGN-102. It starts out as a liquid when it's cold. When I put it into the bladder and we use it in upper tract disease, it turns into a gel, so it actually sits on wherever it is. So there's different types of therapies as well as different ways to put them in the bladder. So that was my whole point in just kind of opening your mind up to what is out there for patients. And there's a lot of stuff coming down the pipeline. 10 years ago, we did not have any of this. I had like 3 treatments I could use for non-muscle invasive. How long have I been?
You're good.
Am I good? Okay. So I want to just talk about BCG, how we think about whether patients or not respond to BCG. And I don't want to get lost in the weeds about this, but you have to understand this if you are a bladder cancer patient. So there's BCG intolerance. That means I gave you BCG, you got horrible pain in the clinic, you got a fever, and we couldn't do it anymore. You couldn't tolerate the treatment. Then we have BCG unresponsiveness. That's either you're refractory or you're relapsing. Refractory means that the cancer just doesn't go away. It still stays in there even after you get the BCG. Or you get more tumors. Relapsing is where I got rid of the cancer with the BCG, but then it came back within a certain period of time. It's usually about 6 months, okay? These are very important because the different trials and the different drugs are approved. Some are approved for patients that haven't had BCG, and some are approved for patients that have had BCG and failed. And man, are they expensive. So you want to be very clear when you're a doctor about documenting whether the patients have had these treatments or not. That's why this is so important for patients. I'm not going to actually go, you don't have to worry about that. The other thing is adequate BCG. How much treatment have you had? You have to have the 6 doses plus 2 more, or it is not considered adequate therapy. So if you made it through 4 treatments, you're not a BCG failure yet. You just didn't get enough based on these diagnoses. And again, this is important stuff to document, because when I have to go back and I have to tell the insurance company, no, I need to give the patient these drugs, They want to see these things, right? It's very important. And then let's talk a little bit about genetics, which is also changing the way we treat our bladder cancers. So there is a lot more focus on bladder cancer, even in non-muscle invasive, on the genes and the mutations that cause the bladder cancer. This is important because that's how we're going to make the drugs. If you know the mutation, then you can make a drug that targets that mutation. And I'm sure you guys are going to talk a little bit more about that too. So some of the few, FGFR is a very popular one. It's usually found in low-grade and upper tract tumors. And then T53 and RB are these mutations that we always kind of focus on, and there's different drugs that we can use to target those mutations. There's a lot of trials in naive BCG, so patients that have not had BCG yet. So how do I figure out if I have a patient with high grade, we know BCG 86% of the time helps get rid of the cancer. How do I decide, well, should I put that patient into a trial first and then use the BCG to clean up things later if it doesn't work? I mean, these are the questions that I have to ask myself every day, but I think I want you guys to understand all the things that are out there now. It is complicated. I feel like a medical oncologist now. It's hard. I used to just cut things out. And then this was a great, again, this is just to show you what's out there. This is for intermediate risk and high risk. These are all the clinical trials right now for non-muscle invasive bladder cancer. This was a great graph from, it's actually a book that was put out by ASCO, which is like a medical oncology group. And they went through all the trials. And there's, if you guys want to look at the data, it's right there. So I think this landscape is vastly, vastly changing for patients. And I think urologists have to figure out how to navigate all these different treatments and trials. And like I said, the biggest thing for me is sometimes the trials outperform our regular drugs that we have now. So how do I know when to put the patients in there? And that's based on their age, where they are, their access to the trials, and their tumors. So I appreciate your attention today. Thank you guys very much.
Dr. Linehan, that was fabulous. And now I'm going to turn it over to Dr. Rose, but I just want to point out one thing, and I'm surprised that you didn't know this, because you do know this. We like to say that patients don't fail treatment.
I didn't know that. Did I say that?
The treatment fails the patient.
Yes, the treatments fail. The treatments fail. The treatments fail. Thank you. Thank you.
I just want to clarify.
I did say that. Thank you.
I know. So anyway, thank you so much. So now let's switch over. Because again, 20 years ago, radiation was not really on the scene for treating. And now today, there's so many ways that it can be used. Maybe it can prime that tumor, make it more receptive to all the other things that are out there, or maybe it's part of the whole bladder preservation strategy. So Dr. Rose, take it away.
Well, thank you so much. You know, I have to say, I've never been in a conference like this that was so free-flowing. I can walk around. I don't have a hand microphone. This is great. Yeah, I really appreciate that. Well, thank you, everyone, so much for having me. It's really a pleasure to be here. My name is Brent Rose. I'm a radiation oncologist at UC San Diego, where I take care of a lot of folks with bladder cancer. And so I want to talk today about bladder preservation therapy for muscle-invasive bladder cancer. There's not as much information about that as we might hope there to be, and a lot of it is a little bit more confusing, so I hope we can kind of clarify some of the key points here. So, you know, I'm also, whenever I come and talk with patients, I'm always impressed how much some people know. It's really incredible. You know, when you've been on this journey for a long time, you've studied all about things, but everyone's on a different point in their journey. Some people are just learning, some people are just getting started. So I do want to kind of take a step back and go through some of the basics and just make sure we all understand what we mean when we're talking about muscle invasive, non-muscle invasive bladder cancer. So when you think about your bladder, it's essentially a reservoir, almost a bag that just holds the urine until you're ready to pee. But it's lined by muscle because the muscle has to squeeze in order to get the urine out. So if you look, kind of focus in on the wall of the bladder, we can show you kind of the layers of the bladder wall. So you can see the very first layer is really just what we call the urothelium, and that's sort of like the skin on the outside. It's the layer that's on the inside of the bladder. And right below that, there's just a thin connective tissue layer. When their cancer is in that area there, we call that non-muscle invasive bladder cancer, and that's really managed the way that Dr. Linehan discussed with all the different options, lots of different ways to do it. But sometimes the tumor grows beyond those layers and goes into the muscle that's underneath. And this is a much bigger problem. The reason is once it gets into that muscle, then the cancer cells can kind of spread around, both in that local area and also jumping into lymph nodes and outside of the bladder. So it's a much more serious condition once the cancer gets into the muscle wall. So we tend to call that muscle invasive bladder cancer. So that's a term you've heard a million times, non-muscle invasive, muscle invasive, and that's just kind of the diagram to show that. And then one thing that's implied when we say muscle invasive bladder cancer is usually we mean that the cancer hasn't spread to bones and lymph nodes and outside of the pelvis. We consider that metastatic cancer instead. So when we're saying muscle invasive, we usually mean that it's localized to the bladder. And so what do we mean by bladder preservation? So, you know, a lot of people have been through this cancer journey for a while, and you've heard cystectomy, 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 and it's a great option. It really is a good option, usually with some form of chemotherapy as well, because there are very high cure rates here. It's really one of the standards of care, one of the best ways to treat muscle invasive bladder cancer. But there are risks. You know, there are side effects, and there are quality of life implications if you take out a bladder. And so if we were to look around and think about other types of cancers, how we manage other types of cancers, we're often trying to push organ preservation. Can we leave the natural organ there and just try to kill the cancer instead of taking the organ out? We do that frequently in larynx cancer, anal cancer, even now rectal cancer. The standard of care in these is really to try to preserve the organ with some form of chemotherapy, radiation therapy, and a local therapy as well. And so in our case, bladder preservation with trimodality therapy, and that's usually a transurethral resection, chemotherapy, radiation therapy, is actually a very effective technique, but it's really underutilized for a lot of reasons. And so I just want to kind of walk through each of those pieces so everyone's familiar. And I know a lot of people have probably had these procedures, a transurethral resection of the bladder tumor. But essentially what that is either in the office or in the operating room, one of the surgeons or urologists will go in and try to remove as much of the tumor as they can. And in those non-muscle invasive cancers, like we mentioned, usually you can get a lot of it, all of it, and then hopefully maybe with some treatment in the bladder, that would be enough. But you can see when that tumor is getting into that bladder area, it's really hard to get all of the cancer cells out with that TURBT. You can also imagine you don't want to go all the way through the bladder with this procedure because then you could kind of put a hole in the bladder, and that's pretty complicated. So you do raise the risk of leaving some cancer cells behind there. But when there's only a small number of cancer cells left behind, that's where the chemotherapy and the radiation is going to work the best. So the other component, radiation therapy. So I'm sure a lot of people haven't had radiation here, but if you ever do, essentially what it is you're just laying on the table like our friend here, and there's a machine that we call a linear accelerator or a LINAC that just kind of rotates around you. It doesn't get that close to you. People don't feel claustrophobic. Usually you can't feel the radiation as it passes through. And then if you look at the pictures on the right, you can see we're trying in the advancements of technology to focus that radiation as precisely as possible and trying to target the bladder, but avoid the organs that are nearby, the recta, the small bowel, and things along those lines. And then, of course, there's chemotherapy, and I'll leave that to Dr. Stewart to talk you a little bit more through the chemotherapy. And so I just want to take a second to say, is bladder preservation a good option? So let's take a step back and think of Dr. Linehan's patient. She had non-muscle invasive bladder cancer, but what if on one of those procedures her cancer had grown into the muscle and had muscle invasive bladder cancer? Would trimodality therapy have been a good option for her, or should she have a cystectomy? So in order to answer that question, we have to think about, is trimodality therapy effective? And then, what are the side effects? How do people do when they get trimodality therapy? And then, who are the right people that we should be treating with this technique? And then at the end, we'll just quickly talk about a few options about novel approaches, how we can make the technique even better. So just to start off, the efficacy of trimodality therapy. So really, I don't want to get into too much data here, but there's this one big trial called BC 2001 that was done in Europe. And they randomized patients with muscle invasive bladder cancer to radiation to the bladder versus chemotherapy and radiation to the bladder. And chemotherapy and radiation to the bladder was much better than radiation alone, so that's now the standard of care. And so if you look at the group of patients that got chemotherapy and radiation together, you actually see pretty good outcomes. About 80% of the patients did not have invasive cancer recurrence in their pelvis. So about 80% of patients didn't have a recurrence in their pelvis. And those who do often can still get a cystectomy, so you haven't lost the chance to get a cystectomy. In this case, about 14% of patients had to have a cystectomy because the cancer came back. And I don't want to sugarcoat things because there are significant side effects from the treatment as well. And so about 1.3% of people had to have their bladder removed just from a side effect of the chemotherapy and the radiation. So that does happen, but thankfully it's fairly rare, 1 or 2%. So the big question, of course, is trimodality therapy as effective as a cystectomy? The hard part is we don't know, because there's never been a study that randomized the two together and said which one is better, surgery or radiation. But if you look at trials of chemotherapy, radiation, trials of surgery, they look like they're in the ballpark. So we can't say definitively that one is better than the other, but we do think that this is a fairly reasonable option for the right patient. Not all patients, but for the right patient. So then we wonder, what are the side effects of the treatment? Is it going to be really hard? Are there really going to be bad side effects? And so luckily in the BC 2001 trial, they also gave patients questionnaires right before they started the treatment, right at the end of the treatment, and at various time points afterwards. And this one specifically focusing on bladder quality of life. And you can see that from the beginning to the end of the treatment, there's a big impact of the treatment. This is exactly what we'd expect. Right at the end of the treatment, peeing a lot, it burns, you're waking up at night to pee, maybe having some trouble with control. That's what we expect during the treatment. But after the treatment, 6 months, a year afterwards, most of the patient's quality of life has returned pretty close to normal again. So certainly some effect during the treatment. Longer term, usually we get pretty good outcomes longer term in terms of quality of life for the bladder. And then, that's averages. We look specifically about patients, individual patients, and then specific domains, urinary control, urinary frequency, diarrhea, and erections. And it's essentially the same story again. From the beginning to right at the end of the treatment, worsening of urinary control, worsening of urinary frequency, definitely a lot more diarrhea. But over the longer term period, months to years after the treatment is over, most patients end up pretty close to where they were before the treatment was started. But I don't want to sugarcoat that, because there are significant side effects of this treatment. And I don't want you to leave thinking, oh, everything will be just fine. Because some people do have a long-term worsening of their bladder function. If you looked at the surveys, about a third of patients will say that their bladder function is worse than it was before the treatment started. And so that's when I talk to folks about, is this a good option, we'll say, your urination is probably going to get worse. About a third of the people say it's significantly worse than it was before the treatment. And about 1 or 2% of people are probably going to have such bad side effects that the bladder has to come out. But that also means that 80% of people are living with their own bladder with side effects that are manageable and not too bad. And when you compare it to having your bladder come out in the first place, that's a discussion that we should probably be having with a lot of patients. Is this something that you want to go down? And it's really important to have this discussion about efficacy and side effects, because it's really important to have a balanced discussion, have a team approach where you're talking to a medical oncologist, talking to a surgeon, and really laying out, is this the right option for me? Okay? So we have to think also, who are the right patients? So I mentioned that the efficacy, generally speaking, is pretty good, similar to a cystectomy in the appropriate patients. We talked through the side effects, but what we really want to know is which is the right option for that patient. So there's two big things in the back of our head. First is, are you a good candidate for surgery? Cystectomy is a big surgery. Sometimes people are older, have some medical issues that make the surgery a little bit harder, and so if you're not a great candidate for surgery, then trimodality therapy, chemoradiation is probably going to be the best option. If you are a good candidate for surgery, then you really want to decide, is this cancer one that is going to be treated effectively with chemoradiation or trimodality therapy? And so there's a couple things we think about. The smaller the tumor is, the better the chemotherapy and the radiation is going to work. Again, when you can go in there and do that TURBT and remove almost all of the tumor and there's some cells left behind, that's the best scenario, because the chemotherapy and the radiation can be very effective in that case. There's also something called hydronephrosis. You may or may not have heard of that. I'll show you a picture, but there's a tube that goes from the kidneys down to the bladder called the ureter. When the tumor in the bladder is blocking off the ureter and causing that tube to expand and get blocked up, that's probably not a great situation for chemoradiation, because that tumor is extending beyond the bladder there, and so that's a lot harder of a situation to manage. Like Dr. Linehan mentioned, CIS or carcinoma in situ, and a lot of other cancers, that's a, oh, don't worry too much about that. In bladder cancer, for some reason, those things are just tough. You do the radiation, and it doesn't work that well against the carcinoma in situ. So if you have a bladder that has a lot of carcinoma in situ, maybe that's not one that we try to preserve with chemotherapy and radiation. And then the other thing to think about is often these tumors have sort of damaged the bladder, And the bladder might not be working very well. You could be miserable with the symptoms you had from the cancer for even before we do any treatment. In that case, are we just going to make that worse? Might you actually be better off if we just took the bladder out and had a better management strategy to get you good quality of life? Because after cystectomy, you can have really good quality of life. And so if the bladder before the treatment isn't working quite right, then this might not be the right option for you. So just to show a few pictures. So on the left is case 1. This is a fairly small tumor in the bladder that looks like a tumor that one of our colleagues can probably go in there and get all of it out or most of it out. It's not affecting the ureter, and so that's probably a case where we're going to have a good outcome. Unfortunately, the case on the right, case 2, this is a bigger tumor. It's kind of extending into the walls of the bladder to the side. You see the blue arrow is pointing at the ureter. It's dilated there, meaning it's blocked off and it's collecting urine because it can't drain into the bladder. This is one of those that's probably not the right option to try to do bladder preservation. You know, sometimes, again, if you can't have surgery, we could try it and try our best and still have a decent chance of curing these. But if you have a good option like a cystectomy, maybe that's the better option in cases like that. So just to summarize kind of what we talked about, chemotherapy with radiation is an effective technique. Side effects are manageable in the majority of cases, though there are times where you get a really bad side effect that sticks with you and can affect your quality of life for the longer term. But really it comes down to who is the right person that we should try this strategy for? Are you really motivated to try to avoid a cystectomy? Or conversely, have you had a friend that had a really bad reaction to radiation before and you're a little bit worried that that might happen to you? And is the tumor one that's gonna respond well, or we expect to respond well? And that's really a shared discussion between you, your doctors, and your team, and your caregivers, your spouse, your friends. Sometimes those sources of support are really important to talk through all the different issues, because quality of life after a cystectomy is going to be different than quality of life and the things you deal with after chemoradiation. So it's an important shared discussion to have. And like I mentioned, the side effects of radiation are real, and we try to minimize them. We're improving technologies, try to be as focused as possible with the radiation, avoiding the other organs. But what if we didn't need the radiation? Wouldn't that be even better? So I just want to point out a study that was a really exciting study, really kind of sent shockwaves through the whole community. This is a study where what they essentially did is they did chemotherapy. In this case, it was gemcitabine and cisplatin, and they give immunotherapy with it, in case nivolumab. And so they gave patients this treatment, and then they looked in their bladder. If the tumor had gone away completely, and that happened in about half of the cases where the tumor had gone away completely, they didn't do any local therapy, so no cystectomy, no radiation. They just observed those cases. In the half where they didn't get a complete response, they went to a cystectomy, took those bladders out. And then you can see what happened over the long term is that in the patients that had that clinical complete response, when they observed them, most of them did not have metastases. The cancer didn't jump out of the bladder and didn't go cause big problems. You know, some of them did have a recurrence in the bladder, but that could be managed with the cystectomy or radiation at that time. So long term, these patients actually did really well. And so this is a really exciting study that came out, but I just want to say, this is really the cutting edge stuff. This is not ready for prime time because we don't know who the right patients are. There was a similar study with a similar framework, and they didn't have quite as good of outcomes. And so there's a lot of things that we need to learn, things that we need to understand to know who are the patients where we can avoid a local therapy, or at least delay a local therapy and observe after our systemic therapies and figure out who are the right patients, how do we identify that person, where we can minimize the side effects of all of our treatment. Because that's really the goal. We want to cure these cancers. We need to give enough treatment to cure the cancer, but not so much that we leave you with a big quality of life issue after we've cured the cancer. And so that's really the goal. That's what we're trying to get. Every year there's a step in the right direction. We're not there yet. We need to do a lot more, but that's really where we're trying to get to. So thank you so much for your time.
Remember to write your questions down. I hope you're seeing this sort of pattern, that it's not just urologists and medical oncologists now, but now we've got this bridge where the whole team of radiation oncology is coming into the mix, helping with many different things. And Dr. Stewart, you do such a great job of really highlighting how things have evolved. You used to have the option of chemotherapy, and if that didn't work, get your affairs in order. And now you have a lot more options for patients. So this would be great. If we can get the next slide deck, that would be awesome.
While they're getting the slide deck, Stephanie, thanks so much for Beacon for putting on this event, for inviting me to talk at this event. Certainly, this is just an amazing advocacy network. You guys do so much amazing work. I am a medical oncologist. My name is Tyler Stewart. I'm a medical oncologist here at UC San Diego, and I will tell you that I see patients with bladder cancer every single day, and I am letting them know about Beacon as early as possible now, just knowing all the great resources that this organization supplies, and it's just so helpful. Today, I am tasked to talk a little bit about systemic therapy for urothelial carcinoma, both in the metastatic and locally advanced settings. And really what I want to try to do is talk about the advances that we've made over the last 20 or so years. These are some disclosures. So like I said before, so I'm a medical oncologist. Lots of different docs treat bladder cancer. There are surgeons that do this. There are radiation docs. I am a medicine doctor. So I give medicines to treat bladder cancer, urothelial carcinoma. And some of those medicines sound like chemotherapy or immunotherapy, and we're going to talk about those. I focus my treatment and my research on bladder cancer. Biomarkers, something called minimal residual disease, ctDNA. So if you are interested in this stuff, come chat with me afterwards. Today we're going to talk a little bit about advances in metastatic bladder cancer. We're going to talk about frontline therapy, novel therapies, and then we're going to talk about perioperative therapy, bladder preservation, and novel biomarkers. As you can tell, I love to talk. So I will make this briefer than I want it to be, but maybe just a little bit longer than Stephanie wants it to be. Here's a basic terminology for urothelial carcinoma. So urothelial carcinoma refers to cancers that start out in the urothelial lining. This happens anywhere from the collecting part of the kidneys all the way down into the ureters, into the bladder, and then out the urethra. And if you have a cancer that develops there from those urothelial cells, we call that urothelial carcinoma. The vast majority of bladder cancers are urothelial carcinomas, but not all bladder cancers are urothelial. And then not all urothelial carcinomas are in the bladder. Some of them happen in the upper tracts. We call that upper tract urothelial carcinoma that Stephanie alluded to earlier. And you can actually even get them out the urethra as well. We think about bladder cancer based on states, and we've done Dr. Linehan showed this slide, Dr. Rose, but this is so important. So some bladder cancers are so superficial. We scraped those out, and we talked to you about the fact that these oftentimes will come back, and we try to give you medicines into the bladder to prevent them from coming back. But then they get into the muscle layer, and once those cancers get into the muscle layer, they have a higher chance to get into the blood supply and then spread. And for some patients, they do spread, and they get into the lymph nodes, and then they can spread beyond to the liver, lungs, and other places. In patients where the cancer spreads beyond those local lymph nodes, we refer to that as metastatic or stage 4 bladder cancer. And when patients have cancer that is spread beyond those local lymph nodes, unfortunately, surgery or radiation is not going to do the job there. These patients who have cancer that's spread beyond, they need something to get into their body to try to attack the cancer everywhere that it is. And today I'm going to talk about some of those therapies that we've had in the past and some of the therapies that we have now. Historically, we had chemotherapy. So chemotherapy, including something called cisplatin and gemcitabine, these are medicines that have been around for 20, 30 years. We've been using them for a long time. And we've been using them to treat bladder cancer. And in patients who have bladder cancer, when we use regular old chemotherapy, the tumors significantly shrink around 50% of the time. But when they shrink, after a while, they usually end up growing. So then the trouble is that this chemotherapy isn't curing. And when earlier today we talked about that C word, when you're in the office and you're getting that diagnosis of cancer, that is the major word that you hear, cancer. But what we want to think about is, can we think about curing? And so chemotherapy by itself gives you response rates, makes tumors shrink, But over time, unfortunately, the vast majority of patients will have their cancer grow. So then these things called checkpoint inhibitors or immunotherapies were invented. So we've been using these in the clinic for the last 10, 15 years. Checkpoint inhibitors or immunotherapy use your body's immune system to try to rev up and attack the cancer. And these have revolutionized cancer therapy, and particularly urothelial carcinoma. So the trouble with these checkpoint inhibitors, that they only work around 20-25% of the time for urothelial carcinoma. But if they work, they can take those tumors and they can shrink, and they can work for years. And we probably even cure some patients just with these immunotherapies, even for patients where the cancer is spread. And for those reasons, the people who did the pioneering work won the Nobel Prize about 4 or 5 years ago. But the trouble is these immunotherapies don't work all the time, and so we have to come up with new therapies for patients to give patients options. At one point, we started saying to ourselves, well, listen, chemotherapy is pretty good, and then we waited until their cancer got a little bit worse, and then they gave them immunotherapy. And then we said, well, why wait? These things are amazing. It's like winning the lottery, and you can't win the lottery if you don't buy a ticket. So why don't we just give the immunotherapy right away? Give them some chemotherapy, calm the cancer down, and then give them some immunotherapy. And this became the standard of care for a few years. And then we started saying, well, if chemotherapy is good, immunotherapy is good, why don't we combine those together? We had a couple of trials that tried to do this, and they didn't really show a significant benefit until this study called the Checkmate 901 study, where we tried some chemotherapy with this drug called Opdivo or nivolumab. And all of a sudden it looked like if we gave chemotherapy with immunotherapy, those patients who received this combination did better than the patients who received just chemotherapy by itself. And for about 5 minutes, this became the standard of care. And then we had a different drug come out. So as we start developing therapies, we start thinking about, well, listen, wouldn't it be great if instead of just giving chemotherapy that it kind of goes everywhere in the body, could we target cancer? And so over the last couple of years, we have really been developing drugs that try to target cancer. One of the ways that we do this is through something called an antibody-drug conjugate. Now, this is a complicated picture, but I think about it more like this. So an antibody-drug conjugate is a molecule that has a specific target that it goes after on a cancer cell. And it's linked to a little bit of chemotherapy. And so you can imagine, well, can we develop some antibody that attacks something that is usually on urothelial carcinoma or bladder cancer? And so this is what we've been doing in medical oncology for the last many years, 5, 10 years. And so we are trying to find cancers that have one of these targets that come up all the time, and then targeting them with a new medicine. The first of these that were used for urothelial that really came to fame was something called enfortumab vedotin, or the other name for this is Padcev. This targets something called Nectin-4. It's highly expressed on urothelial carcinoma, and it's linked to a little bit of chemotherapy. And so how this goes is the drug binds to the cancer cell at that target, gets internalized, lets the chemotherapy go inside the cell, and then boom goes the dynamite, cancer dies. So it's a great idea. Does it work? Well, the very first time we started putting these in patients, and actually I was a fellow in a clinic where these were being used, and I was seeing these patients respond for the very first time. Now listen, these are not magical drugs. They don't work for everyone. But for about 40 to 50% of patients, there was a significant response when we were using some of these drugs. And for patients with metastatic urothelial carcinoma, we weren't seeing those numbers. Then we tried in big trials, hey, listen, is this drug any better than chemotherapy? And it looked like it was. So this became a new line of therapy for kind of patients who were no longer responding to chemotherapy or immunotherapy. But then we said, well, that looks really good. And I don't know if you know this, but if we try drug A and that works, and we try drug B and that works, why don't we try drug A and B together? And so somebody had an idea of this immunotherapy is real good, this drug is real good, let's try to put them together, this enfortumab vedotin and pembrolizumab. And at UCSD, we were part of some of these trials where we were looking at the combination of these drugs, and in about 70% of patients, they were having significant shrinkage of their tumor. And we said, wow, that looks really good. Are we seeing the future of what we should be doing? So a large study was done called EV302, which compared enfortumab vedotin and pembrolizumab to getting chemotherapy. And what you can see on this curve is that there are two lines. There's a dark blue line and maybe a gray line. My colors are not very good, but I think that's roughly right. And what you can see is that that is an overall survival. And if you were getting the enfortumab vedotin and pembrolizumab, you had a much higher chance of being alive at 1 year and 2 years than getting the chemotherapy. Not only that, but in about 30% of patients, if you got this combination, we were seeing all of the cancer go away on scans. Now, that doesn't mean that 30% of people are cured with this stuff, but 30% of the people are seeing a significant reduction such that it's so small on scans that we can't see it. It might come back in the future, but that's pretty hopeful. And now, this combination is FDA approved, and this is our standard of care frontline therapy for patients who have advanced urothelial carcinoma. I will tell you that we saw the writing on the wall, and maybe we gave this a little bit even before it was FDA approved, because this was just clearly going to be the thing. Unfortunately, enfortumab vedotin and pembrolizumab, as great as that combination is, doesn't work for all patients. And some patients, they will respond to this, but then eventually their cancer may stop responding to this. And so we have to think, what else can we do? What is our next line of therapy? Well, one thing is that we could give chemotherapy. But it turns out most of the chemotherapies that we have don't have a high response rate in the second and third line setting. So we said, well, we used to have immunotherapy, but now we give that in the front line. And what else can we do? Well, let's look at other ways that these cancers make mistakes and we can target them. And one of them is something called FGFR. And we heard Dr. Linehan talk a little bit about this before. So some cancers, some urothelial cancers, have a specific mutation in something called FGFR. And it turns out when your cancer has a mutation, sometimes we can develop drugs that target that mutation and tries to kill the cancer. And so there's a drug called erdafitinib that is an oral pill that can take that is an inhibitor of FGFR. And when we started using that in clinic, what we saw was that in some patients with these FGFR mutations, we saw significant reductions of their cancer and helped patients live longer, happier, healthier. It's not curing people, but it is helping people live longer, happier, healthier, and now this is FDA approved. This drug comes with some side effects, and so there are some novel therapies that are being developed in this space that are trying to get the same efficacy but less toxicity, and we're really excited to be part of those studies as well. That's great. What else can we do? So there's the idea of these antibody-drug conjugates that develop antibodies that target something and then link it to some chemotherapy. Well, can we make more of those? Well, there's one drug called sacituzumab govitecan. This is the same idea. It targets something a little bit different on cancer cells called TROP2, goes to the cancer, and then once it hits the cancer, gets internalized and releases a different type of chemotherapy. This has a response rate of around 27%. This was FDA approved with an accelerated approval, but then some phase 3 studies didn't look as good. This is still something that we think about using in clinic. But there are also other drugs that are out there. So this drug is trastuzumab deruxtecan. This is a drug that was used, it targets something called HER2. This is very prevalent in breast cancer. But it turns out that a lot of bladder cancers also express this thing called HER2. So we tried this drug in bladder cancer. And in patients who have a high expression of this HER2, this works in around 60% of patients. Again, we're not curing patients with this drug by itself, but this is causing significant shrinkage of tumor for many patients and helping patients live longer, happier, healthier. There are other drugs that are being developed in this space as well. This is another medicine, very similar. This is called dasatinib vedotin. that is also showing significant efficacy, and we're excited to be studying this further. There are tons of these antibody-drug conjugates that are currently in trial. So right now, in our clinics, we are trialing new drugs to see if they can help patients shrink their tumors, live long, happier, healthier. We are looking for the next enfortumab vedotin, the next drug that is going to revolutionize our cancer care. And when we have big hits for patients where the cancer is already spread, we start asking ourselves, can we use these for patients where the cancer is not yet spread to help prevent it from spreading? So once again, we talked about muscle invasive bladder cancer. This is cancer that is within the bladder, but might be close to those blood vessels and puts patients at high risk for that cancer spreading. Earlier today, I was asked, we talked about cystectomy, and a patient asked, what are the chances after a cystectomy that your cancer is going to come back? Well, it's actually dependent on how much cancer was in that cystectomy specimen. So how much cancer is left over in that bladder. If there is only a small amount of bladder cancer that's left over after a cystectomy, the chance that that cancer will come back is small. Maybe 15%, not nothing, but not 80%. But if there's more significant amount of cancer in that bladder, maybe there's still some cancer within that bladder wall, maybe 40 to 50% chance of it coming back. And higher if we have lymph nodes when we take out the bladder that are positive. So oftentimes what we'll do for patients who have muscle-invasive bladder cancer is that patients will come to see me, a medical oncologist, and we'll have an honest conversation and say, hey, listen, if you go and have surgery, maybe there's a 40 to 50% chance of the cancer coming back. Maybe what we should do is give you some chemotherapy now, kill off any cells that might be swimming around that have left that bladder, and then after we're done, we go back in there and have Dr. Linehan take the bladder out to try to cure all of your cancer. So that is the standard of care as of today to think about neoadjuvant chemotherapy. In addition to that, if we do all of that and we still think that you have a high chance of the cancer coming back, sometimes what we do is we actually use that immunotherapy to prevent the cancer from coming back, trying to get rid of any cancer cells that we can't quite see on scans that might be there. There are a number of studies that have been done. This one is called the Checkmate 274. We studied this drug called Opdivo. You may have seen it on TV. And it turns out that when we give Opdivo for patients who are at very high risk of their cancer coming back, this decreases the chance of the cancer coming back. More recently, there's a study called the Niagara study. I don't know how these studies get named. Somebody's hanging out and some falls somewhere. Anyways, so this is a study of giving some chemotherapy with immunotherapy to patients with muscle-invasive bladder cancer. And what this study showed is that if you gave chemotherapy with immunotherapy, this had a higher chance of curing patients than if you gave just chemotherapy alone. So certainly something that we think about even now in the office. So this is awaiting FDA decisions, but already some practitioners are thinking about doing this. EV plus pembrolizumab, we talked about that being the standard of care for frontline metastatic setting. There are current ongoing studies that are looking at the use of this combination for patients with muscle-invasive bladder cancer. Those data are highly awaited, and I certainly think there's a good chance that they may change the standard of care and increase the chance of being able to cure patients who have muscle-invasive bladder cancer who are planning on undergoing a cystectomy. Earlier today, we talked about bladder preservation. How can we use medicines to help bladder preservation? Dr. Rose talked a little bit about this trimodality therapy where we're trying to save the bladder. So we use chemotherapy to damage the cancer cells so that his radiation is more effective. The radiation is the lion's share of the work here, but the chemotherapy here kind of hurts the cancer cells to make that radiation more effective. if you put a gun to my head and asked me which one is better, radiation or cystectomy, I'd say, I don't know. It's a personal decision, and we don't have a lot of good data. We actually tried to run a clinical trial, but it's hard because if you picture yourself having a conversation with the doc and saying, hey, listen, you got cancer that's in the bladder, and we'd like to randomize you to either radiation or surgery, you might say, well, I don't want to be randomized, or I don't feel comfortable with that. I'd like to make my own decision. And honestly, the docs might have. And so when we tried to do a clinical trial, it didn't accrue because patients said, I want to make that decision. I don't want a computer to flip a coin and make it for me. So we have to rely on some retrospective data. The truth is the retrospective data support that radiation to the bladder is a very good treatment modality for trying to help patients with muscle-invasive bladder cancer cure their cancer. But you got to be the right patient with the right bladder, and it has to be the right thing for you. The other thing that we think about as a medical oncologist is one of the studies that Dr. Rose was talking about. This is a study where patients had muscle-invasive bladder cancer, where the standard of care is to take that bladder out or zap it with radiation. And what some of us are saying is your medicine, are your medicines so good that for patients who have such a good response to chemo or immunotherapy, is it good enough to cure the cancer in the bladder alone? And then maybe we could just, if it does a really good job, maybe we could just leave patients the hell alone. And this is one study that showed that maybe we're onto something with this. Maybe if somebody has such a great response, we might be able to think about that. That is not ready for prime time, but that is where the field is going. And I might encourage Beacon to really look into these studies as when they're thinking about which studies to support, because I think these are next level stuff. Novel biomarkers. So this is another thing where we are leveling up how we are trying to meet patients where they're at, trying to treat the patients who need to be treated, who are at the very high risk of their cancer coming back, but also trying to defer treatment for patients who don't need it. There's this thing called ctDNA. So it turns out that if you have bladder cancer that's invaded into the muscle wall and then you get your bladder taken out, we have now developed these really sensitive blood tests which can look for cancer DNA in the blood. And if you have had surgery and you removed all of the cancer that we should know about, but you still have cancer DNA in the blood, that probably means you still got cancer in your body. And now we are starting to use these blood tests to determine which patients need additional therapy after their bladder is out. This is one trial that we're running at UCSD. It's a national study that I happen to be pretty involved with, where we are trying to determine which patients actually need immunotherapy after their bladder is taken out based on some of those blood tests. Trying to escalate therapy for those most at risk, and maybe de-escalate therapy for those who might not need it. There are lots of these blood-based assays that are being developed, and we're working on that at UCSD, and these are being worked around globally. The other thing that we're really excited about is, well, if you can detect cancer in the blood, I'm not sure if you know this, but there's another source where these bladder cancers come out. And so the question is, can you detect cancer in the urine? And for those of you who are undergoing cystoscopies on a pretty regular basis, wouldn't it be great if instead of getting a cystoscopy every 3 or 6 months, if you could just pee into a cup and just know if you had cancer there? And maybe I'll do the cystoscopy if there's positive, but maybe I can avoid a couple of scopes if my urine is clear. Those assays are being developed, and I think over the next 3 to 5 years, they will become increasingly prominent and maybe change how we are practicing bladder cancer surveillance in the clinic. So that's just a little bit of where we've been for systemic therapy. and some of the advances we've made for patients where the cancer has spread, and how we are using some of that knowledge to help patients where the cancer is still localized to increase cure rates. Thanks so much for your time.
Okay, so now let's open it up to questions. If you have a question, please raise your hand. We've got Bernadette and Patricia here to do questions. We'll kind of bounce back and forth.
Yes, thank you for letting me take my question. In 2019, I was TACIS. 2 years later, after a little BCG, because they're off and on, I went to T1. I made the decision after I failed Gemdosi to then have an RC, neobladder. I had a surgeon trained by Dr. Ann Schuckman at USC, and they took out 46 lymph nodes. When he did the bladder after, there was no cancer, no tumors, but I went to a lymph node. He says, and he never really answered why that happened. And so after that, they tried to put me in cisplatin, and I was very, very ill from the neobladder. So they put me in nivolumab for 23 infusions. And now I'm having a hard time getting PET scans because my oncologist now keeps telling me, you're just localized metastasis. And my other surgeon, my other doctors have told me, oh no, it's throughout your body. You know, no, it doesn't mean it's just that area. So I don't know what to do. And also, it's a sarcomoid features tumor. I don't really know what that is.
Yeah.
So if you could just help me with what's he talking about?
Yeah. Great. So there are lots of things to unpack there. So maybe, do you guys mind if I just start? So there are a couple things that I might say. So I sit on some of these panels on a relatively frequent basis. And what I can say is that for these panels, we are pretty good at answering good general questions. General questions about what is this with bladder cancer or that. When it comes to questions specifically about patients, I would give just a lot of hesitancy about giving any kind of advice to anyone during these panels, because it really does take a doc to sit down, really go through a chart, to really analyze exactly what might be the right steps forward for you. For your questions, here are some of the things that I heard in the questions that you asked that I might be pretty apt to able to answer. The last question was, what the heck is this sarcomatoid thing? So a sarcomatoid is when a pathologist on any type of cancer sees that these cells are derived from a lining cell called a carcinoma. Here, it would be urothelial is where it's derived, but somewhat look like a different type of cancer called a sarcoma. And we see this in bladder cancer, and I also see kidney cancer as well. So we see sarcomatoid clear cell carcinoma and sarcomatoid urothelial carcinoma. What we know about cancers that have sarcomatoid features is that they tend to respond. First off, they tend to be aggressive. They are aggressive cancers by themselves. But they tend to respond pretty well to immune checkpoint inhibitors, these anti-PD therapies that have been around for 9-10 years. And so before, they might not respond too well to chemotherapy, but now in the era of having these checkpoint inhibitors, we have these nice treatment options for patients that don't always work, but when they work, can work for a long time. So the second question was about PET scans, CT scans, and what we should do. And this question is actually a very difficult question. You know, it used to be that for patients where the cancer had spread, and we had patients who had chemotherapy, we gave them chemotherapy for cancer spreading, unfortunately that cancer was going to come back. And the life expectancy for patients when the cancer spreads was not very high 10, 15 years ago. But now we have patients who respond extremely well. I mean, they might be cured with some of the novel therapies that we have. And so for patients who are doing so well, 3, 4, 5, 10 years out, we don't know exactly how we should follow those patients. We don't know if we should be getting CT scans every 3 months, 6 months, yearly. We definitely don't know if we should do a CT scan or a PET scan. This is the Wild West. So I would say that the questions about which one should we do, CT scans, PET scans, is a difficult one in general. And certainly as we have expanded how good our treatments are. And they're not where we want them to be, but they are certainly better than where they were. We are finding ourselves in these clinical situations. And then, if a doc doesn't know, what do you think an insurance company's going to do? I mean, so like these are tough situations. So that's to say that I don't have a great answer about the imaging modality. I do follow my patients still with CT scans, PET scans, but we have conversations, and if you're 5, 7 years out, we're having conversations about how often we need to do this. And some patients want to be a little bit more frequent with those scans, and some people, never want to see me in clinic, and the fewer the better.
Yeah, a lot of patients like that reassurance that there's nothing that they can find. And so again, thank you for bringing that point out. I didn't say that, but the doctors can answer general questions. It's really hard for them to get specific if you give us really specifics. I'm really glad that you brought up, Joe, the point about the rare variants, the rare histology or the variant histology. Bladder cancer is not that easy. It's not just, urothelial cells. There's weird things within there, and those weird nuances require doctors who were surgeons by training to now understand more than they got in that session, that semester in medical school about genetics. You now have to do a deeper dive into this because now you're applying treatments with the knowledge of what these variants are genetically, and we're really doing a lot we know so much more than we did 20 years ago.
So to Stephanie's point, so as a urologist, I never used to look at the mutations in the tissue. That was something the medical oncologist did to figure out if they could use a targeted drug to treat the cancer. But now that we have so many intravesical therapies, I'm often also doing the tissue testing for mutations to see what I can use and how the tissue is going to respond.
That has been a huge game change in the bladder cancer space. Yeah. So Bernard?
Yeah, I have a question, Doug Cappiello.
Yeah.
First of all, I want to thank everyone on the panel. The presentations today were absolutely awesome. It's probably the best, it's really the best overview of treatment for non-muscle invasive and muscle invasive cancer that I've seen in a very long time, or if ever. I have so many questions, but I'm going to kind of limit to the part on non-muscle invasive by Dr. Linehan. And I think those of you who were at the think tank last summer remember Dr. Ashish Kamat gave, I think, a very good overview. He called it something to the effect of, when is it too much bladder preservation? And I thought it was great, and he gave us some optimism that there's a lot of new treatments coming out. But I kind of left there thinking, I better be careful if I had non-muscle invasive that didn't respond to BCG and maybe to another agent. Maybe it's time. And I certainly think your patient, which was I've never seen anything like that, actually. I've never spoken to anyone who's tried so many different modalities. But I think she would have definitely been in his category of too much. So I just have just kind of a basic question and then more of kind of a philosophical question for you. The first is, in that particular patient with the pathology showing T1 high grade with CIS, how important is it if you look at someone who's got lymphovascular proliferation and also cellular variants? How does that affect your recommendations?
I still think in those cases, even if they have lymphovascular invasion on the pathology, I don't think we have enough data to say, okay, that person is really going to, need a cystectomy. I'm still thinking about intravesical therapies in those settings, because I think you do see some sort of local, what I call more local lymphovascular invasion that's not going to necessarily spread. And so for me to make a drastic call, like a cystectomy, just based on that, we just don't have that data. So those patients, I still think intravesical therapy is helpful.
How about for a variant, like a micropapillary or something like that?
Micropapillary is a very different ballgame. They scare me a little bit more as far as their ability to be more aggressive. And again, when I say aggressive, not only aggressive locally, like through the bladder, but also out into other organs. I might be having a bigger discussion with that patient about cystectomy, because also all of the data that we have on the intravesical therapies, there's not a lot of data on those patients. They usually get cut out of the trials, so we don't know. I only know what I know from clinic, that there are some things that have worked in those cases.
Can I just ask,
Yeah.
so Dr. Linehan, how important is it that you are actually seeing the amount of cancer in the bladder? I mean, we medical oncologists, radiation oncologists, and maybe patients might hear, CIS, T1 high grade, but maybe there's a different feel of a CIS that is kind of a small amount of CIS than a lot of CIS, and maybe that kind of, shaped how you're having that conversation with a patient. Maybe it's not just a diagnosis, but actually seeing the amount of cancer that's there. How does that play into your conversation?
Definitely think if there's a lot of tumor that you're seeing,
Yeah.
that is a very clear distinction that this is going to be aggressive, and maybe you need to not do 6 intravesical therapies, right? And if you have, but with CIS, even if I see sometimes one little spot,
Yeah.
that still is like all of a sudden that patient is now in a different category,
Yeah.
right? So I think with papillary, where I actually see the papillary tumor and there's only one little one, there are studies, and the NCCN guidelines say you can just cut that out. You do not have to give intravesical therapy. And that's where you have the NCCN guidelines, you have the AUA guidelines, you have the European guidelines, and then you have the other bladder cancer group that I was talking about, where anyone that's high grade, if you have a high grade, I'm probably going to give you intravesical therapy. But not all of the societies feel that way. They say if you have a little small tumor, you can just cut that out and you're done. You don't actually have to give more stuff. So there's still some question about that, to your point.
And the second part of my question is more philosophical. So, as I said, I've spoken to dozens of bladder cancer patients. I've never seen anyone who's gone through that many modalities. And I guess philosophically, how were you advising her throughout this course? I mean, it's a question, right? You don't know. A percentage of CIS patients are very aggressive, and they progress and they metastasize. You don't know which are which, right? How were you advising her along this course? Were you pretty comfortable with it, or were you starting to get very uncomfortable early on?
So, now don't tell any of the other surgeons who know me, but I'm a big person for bladder preservation because I've seen it work in numerous situations. There's still some very good evidence where cystectomy is very helpful, and I think these guys would attest to that too. From the moment that she walked in the door and had CIS, there's already like a 20% chance she could have disease somewhere else, right? And so I was thinking every time am I prolonging her? Is she going to get lymph node disease? Is something else going to happen? And so we would often have that conversation. And that's a conversation between her and I, right? Here's the options, here's the risks, here's your chances of being metastatic by the time we get, to cystectomy. And she understood those. And she wanted to push forward with bladder-sparing treatments. And I think if you have that conversation and the patient understands what those risks are, it is ultimately her decision, right?
Yeah, I might echo that purely on the philosophical level. Really, the days where the doctor came in and said, you're going to have this, they're kind of over, right? They should be, because this is a discussion. A cystectomy is a life-changing thing. And so there's no algorithm that perfectly matches this cancer needs this treatment, because you might be fine with the cystectomy. And a lot of people live a wonderful life with the cystectomy, but you might not. And so your personal preferences, how aggressive you want to be with your cancer, what your goals are in your life, and they're so important to this decision-making process that we really shy away from saying you have to do this because of this one thing that we see, and much more of well, these are the options that we have. This is the most aggressive one, and the odds that this is going to work are X. These are the less aggressive ones, and the odds that this is going to work are Y. Which one fits you best? And of course, if you say, I don't know, doctor, tell me what to do, we'll tell you what we think is best. But we really need to have that shared discussion with you, because because this is your life and you're driving this ship and we're trying to help you get to your best place.
Yeah. Dr. Rose, you bring up such a great point. The buzzword these days, shared decision making. How are you guys giving patients their information? But the key is you all need to weigh in and tell the doctors what's important to you. You know, what gives you joy? Is it jumping in the pool with your grandchildren in the summer because they come over every day? Well, if that's the case, then how is the decision option that is given to you as a surgeon, you know, going to influence what makes you happy, what gives you joy? Because saving your life and taking away the joy, that's such a great match. You gotta have joy as well as extended length of life, quality of your life is so important. So I think it's on us as the patient community to remember that as you're making a choice between A and B. Well, how is that going to impact what's important to me as a pop, or you know, a mom, or a sister, or a working person that's still doing things? How are you going to fit this treatment into all that's important to you? So you have a role to play in that shared decision making as well. So yeah, it's important.
Hi, doctors. First of all, thank you very much for your presentations. Highly informative. Very much appreciated. My name is Sid. I was diagnosed with T2 muscle invasive bladder cancer back in November while living in Singapore. And after consulting with doctors in the US and Korea and Singapore, doing a lot of soul searching, a lot of research on my own, I decided to pursue bladder preservation therapy, so TMT. In the end, though, it seemed like it was just a coin flip, and I'm sort of second-guessing my decision every single day. I went through 6 cycles of cisplatin chemotherapy concurrently with 32 doses of proton radiation, and that's why I chose to do it in Singapore, because I had access to proton radiation, which really limited my side effects. I had virtually 0 side effects. Anyway, I finished my therapy about 2 weeks ago. Moved back to America a week ago. Thank you very much. So knock on wood. But I've noticed you've talked about all of these advancements in potential current therapies and potential therapies, like immunotherapies like nivolumab and ADCs like PACDEV, and they're all very exciting. However, most of the trials and research and the cases are for either post-surgery, post-cystectomy, or when the cancer has spread, it's metastasized. But I couldn't find any research or studies for people in my case, people with stage 2 bladder cancer who just had bladder preservation therapy, chemoradiation. And in my non-medically trained mind, the logic is, hey, you've done chemoradiation, the cancer, if it's still there, is as weak as it possibly can be. Why not kick it and stab it with immunotherapy until it's gone? But I can't find any case studies for this. It's only after surgeries, and I'm thinking, why wait till it's metastasized? Why wait till I'm at stage 3 or stage 4 before I can have this immunotherapy or have any of these ADCs? And if you watch a horror movie and some crazy person is coming to get you and you knock it over the head and they're lying unconscious, most of the people in the movie, they say, oh, it's okay now. And then the guy gets up and kills everybody, right? And I'm yelling at the screen going, hey, he's down, now shoot it, throw about 17 arrows in it, light it on fire until it's dead. So I don't think in terms of cancer treatment, there can't be too much overkill. So I'm wondering if there's anything out there to, any progression in my particular situation, because from what I want to do the Signatera test, and if the ctDNA is positive, I want to go right on immunotherapy. And in my layman's logic, it makes sense. I know there are no studies out there, but I'm wondering what you think about this particular situation.
Great question, Sid. So I'll let you all answer because I think he covered all of you.
So first off, congratulations on finishing up this portion of the treatment. And I, having treated a lot of patients with chemotherapy while undergoing radiation treatment, it's not always easy. It sounds like yours went okay, but congratulations. Yeah. So we had a question really about, is there a role for immunotherapy in the case of bladder preservation? And the truth is that there is actually an ongoing study looking at patients who are getting chemoradiation. And the study is called the SWOG 1806 study. And it randomized patients to either chemoradiation or chemoradiation plus immunotherapy. So the study has been accrued, meaning that all the patients that are necessary, and I can't remember, but maybe it's 700 patients or so, have all been accrued for the study, and we are waiting to see about the actual outcomes for the patients and whether or not immunotherapy helped increase cure rates, decrease the chance of these cancers coming back, and we just don't have that data yet. Your point about listen, if the ctDNA test afterwards is positive, I mean, I still have cancer, right? And therefore, shouldn't I get some immunotherapy? There are so many ifs, ands, and buts about that statement, because if we take the bladder out and we still see that the ctDNA, first off, ctDNA is a novel assay that I personally am very excited about and I know a good deal about, but we do not know all of the clinical ramifications of it. And we don't always know how to determine what those tests mean. But let's just say the situation was, I had muscle-invasive bladder cancer and I got my bladder out. If I think that I have surgically removed all of your bladder, and then a month, 2 months later, you still have ctDNA, yeah, I'm pretty concerned that there's still some cancer outside the body, and we should be thinking about other options. But in the case of a patient who's getting chemoradiation, we know that it sometimes takes a while for that radiation to fully kill off all of the cancer cells within the bladder. So if your ctDNA is positive, does that mean that you've got cancer outside the bladder and need additional treatment? Or does it mean you've got cancer that's still within the bladder, that's still dying from that radiation therapy? And then 2-3 months from now, is that ctDNA going to be negative? And it is hard to treat, for docs to give more therapy to somebody who has had a potentially curative treatment without knowing that that treatment is likely going to benefit patients, because all of these treatments have side effects. I talked about immunotherapy, about it being this novel therapy and only works 20-25% of the time, but when it works can be a miracle at times. But we didn't talk about the side effects, and about 10-15% of patients can have significant side effects that really affect their quality of life. Sometimes these can be lifelong. And so, I don't want to give patient-specific advice, but what I would say is that in situations where bladder preservation, we have ongoing studies looking at that concept, but no data in that space just yet to individualize your treatment plans just yet.
I don't want to be the wet blanket on that. That exact paradigm where we did chemotherapy and radiation and followed it with immunotherapy was this really exciting trend that a lot of different disease sites thought was going to be a miracle, a really, really effective strategy. So it was tested in head and neck cancer, tested in cervical cancer, is being tested in bladder cancer, and in both head and neck cancer, cervical cancer, it didn't help. So not to say that that's going to be the result of the bladder cancer study, but you do have to wonder, it's not a slam dunk that it's going to be helpful in this specific scenario. And because of that, you really have to worry about these potential side effects, and they can be real.
Thank you. This is a great presentation. Thank you very much. And those are absolutely the best socks I've ever seen at any Beacon presentation. I've got 2.5 questions. If you can get at least 2 of them, that'd be great. The first is you all talk about standard of care and a lot about BCG and the alternatives, primarily now in non-muscle invasive. It seems to me that a lot of institutions and doctors' offices that treat people, they have protocols. And you all talk about a lot of great stuff up here, but it's extremely difficult when you're treated at places that have protocols to get some of these things done because it doesn't really fit in the protocol. And so, for example, this is question one, can you address why BCG for non-muscle invasive remains the #1 preferred standard of care when there have been positive and somewhat better results so far, or comparable results on things like Antiva and Credo and things like that, which seems to have a better response rate and less progression rate, et cetera. But it comes back to, but our protocol here is really to do BCG. That's question one of the protocols. Question two, if you could address the use of biomarkers, because I think it's the same frustration that there are a lot of things out there, and I'm not affiliated with anybody, but you know, the urine tests, Oncuria and others, and some of the blood tests, which seem to be somewhat predictive with a pretty good confidence rate of who will respond to BCG and some of these other things. But it's extremely difficult, sometimes impossible, to get biomarkers included in what you're going through for treatment if it doesn't really fit into the protocol. And the half question is, if any of you know anything about cohort P with the Bond 3 Credo testing going on, which just opened a few months ago. It's really kind of amazing. It picks up on the gentleman's point. This test was for people who had CIS and papillary, but the test was not available to anyone, or the clinical trial was not available to anyone who just had papillary. You know, if all you had was T1, and it was working great on people with, you know, CIS and T1, but you had to have combination. Now it's been open to participants, I think this cohort P, with people who don't have CIS. And it seems to be another example of there's protocols and all this stuff is great, but in the day-to-day world, why these protocols and BCG first, and two, what about the use of biomarkers as part of the protocol? And thank you.
You're welcome. So I'll try to tackle it. Number one is easy, because BCG has time. You're talking about 20 years of data. With some of these others, you barely have 2 years. So why is it still #1? Because we know that it works for so long over a longer period of time. That's just a data question.
But as you said, there's a high recurrence, and it only works for a percentage of people for a certain amount of time. And I understand your point, but the data that's coming out on a lot of these other things has a much lower reoccurrence rate over that same period of time, and a less progressive rate over that same period of time. So I understand the tried and true BCG, but why isn't there more of some of these other things? Is it because BCG is tried and true, even though it may not be as effective?
Yeah, you're not going to like my answer to that next question. A lot of that is cost. Some of the newer agents are pretty expensive, and so if they don't have as much data as BCG, again, BCG has longer data, right? So we know more about how it works. When things tend to start to become new, there's not as much data that we can actually say this is the reason to use it before BCG, or there aren't comparative trials, or when things are expensive, it can't fit into the paradigm for patients. You have to have trials that say this is as good as BCG or better than BCG. And those trials exist. They're working on them all the time. And that's because the insurance companies won't pay for some of those newer treatments if you don't. You have to have comparative trials that say that it's better than BCG. Those things are coming, and there's a lot of options out there, but they can't get to the head of the line without proving their worth, so to speak.
Yeah, I might say, so a lot of the data, so there are multiple agents that are now new therapies for localized bladder cancer that keeps coming back despite BCG therapy. And a lot of the approvals are in the setting of the patients have been exposed to BCG, but the cancer keeps coming back. And so those drugs have FDA approval, and we are using them in the setting where the cancer has come back despite using BCG. There are ongoing studies right now looking to see whether or not giving these therapies is as good or better than doing BCG in the frontline space. But those data are not quite there yet. As Dr. Linehan said, like some of these studies that led to the approvals of these agents just came out over the last couple of years, and we don't yet have data to show that those drugs are actually better than BCG. And they come with some side effects. And I totally agree with Dr. Linehan. Like, we have to prove that they're actually better than BCG alone before we start giving them up front. I strongly support it.
40 years of history.
100%.
So it's been used for a really long time. So I want to be able to get to, we might have time for 2 more quick questions. There's one here, and then there was one, Bernadette, right here in the front. So let's go to this one first.
This is for Dr. Linehan. I'm 3 years ago diagnosed non-muscle invasive. I've had 2 TURs, the 633 rounds of BCG, and so far things seem good. I'm a retired dentist. I never dreamed I'd become so intimately familiar with the other end. But it's more fun working at my end. But your patient, Rosemarie, it looked like for all the tumors and all that she had just 1 TURBT. And at what point then do you stop chasing new tumors surgically and stop and just count on the chemotherapy or immunotherapy? And in fact, as second part of the question, is surgery still, the TURBT still your primary thing when you see tumors, get them out and count on the intravesical therapies to remove future tumors as well as prevent them?
So I'm sorry, that was my fault. She did have multiple TURBTs. That's how I was getting the pathology every time, and also making sure that it wasn't going into the bladder. I just didn't want to be redundant kind of talking about that in the talk. So she did. She had actually 5 TURBTs.
Okay, so that gets, I'm looking at my own case. If 3 years from now, doc sees a tumor, would you go remove that tumor and do another round of BCG, or continue with just BCG or chemotherapy?
Sometimes I will do an office biopsy, and if they're low-grade tumors and I do an office biopsy and they're low-grade, sometimes I will go right to the intravesical therapy, especially if the patients are older. I mean, putting an 80-year-old, taking them to the operating room, putting them under general anesthesia, every 6 or 8 months, it's not a great idea, right? If they're higher grade, then I really would try to focus on actually cutting out the entire tumor. So I think you have to figure out what it is. So if it's in the office, I'll just do a little biopsy. If it's high grade, then I will take them back to the OR sometimes, depending on the patient's age and their different comorbidities and whether they should have surgery enough and how many times they've already undergone surgery. So all those factors play in when I'm trying to make that decision with them.
Real quick, because we have one more question here. So is it real quick?
It is a quick one.
Okay, go. Go quick.
Thank you. Thank you, Dr. Stewart, for answering my question. I assumed it was in connection with muscle invasive bladder cancer, and I was curious to know what the resurgence, thank you, what the resurgence rate was in connection with non-muscular invasive bladder cancer.
Yeah, so actually if you look at the chart that I had shown prior, so if you have a cystectomy and it is less than muscle invasive disease, so if you have T1 or less, you know, the chances of that recurring outside of the bladder are low, less, you know, when I say low, 15 to 20%, could be less if there's even less amount of cancer in there. It's not 0%, but, you know, that would be roughly the number I'd quote a patient. Dr. Linehan, maybe you'd say something different?
I would say probably 15 to 20%, especially if there was CIS or there was some like variant cancer in there. And it also depends on how much volume of cancer that we was talking about before. That also makes a difference. How much is left over?
Great. Thank you very much.
We have time for one last quick
Hi, I have
question right here.
Quick question. Is this on?
No, can we go to this one? Because he's had his hand up for a really long time. I'm sorry. Maybe you can just be really loud because I want to be sure that we have time. We have a short lunch break, so I just want to, if you could get the mic to here.
So, one or two questions and a comment.
One question. What's the
right,
most important
all
one?
right. So, all right, I was diagnosed in November with a TA, 2-centimeter mass. 95% of it was low-grade papillary, and the other 5% had a high-grade feature. The urologist felt, as a precautionary measure, I should go through 6 weeks of doxy, and now I'm on maintenance. The question is, are there studies out there that have looked longitudinally at how long I should be on maintenance? He kind of felt it was my decision to either do maintenance for a year or two or just do surveillance cystoscopy.
So for BCG, we definitely have that data. It was, in some cases, forever, then it was 3 years, and now because of the shortage, it's 1 year. And there is data on that. For mitomycin, we also have that data. So you should be on maintenance therapy for at least a year. For gemdosi, we are working on that data. So that is more to come. We actually don't know the question with that yet.
Okay. And one more thing, the case study that you gave, when did you ask for consultation from a medical oncologist? You did 5 TURPs, and I just wondered, with that complicated kind of decision-making or shared decision-making, to me it seems like once you have the histology, you really, I'm a nurse practitioner for 25 years, and I would have thought getting an early opinion for both yourself and also the patient would be
So
reasonable.
when she went through 3 treatments, and actually those treatments failed her. 3 treatments failed her, and when we gave her Pembro, she saw the medical oncologist.
Okay.
So she was actually seeing the medical oncologist with me. We were in the same clinic together through her whole course. And we were trying to figure out what to do, because one of the questions I did have was like, should I give her neoadjuvant chemo? I mean, there's not a lot of data, so we had that kind of discussion. She actually saw a radiation oncologist, and I was like, is there any role, in this setting? And I think those studies are coming, hopefully. But yeah, so she saw we're all in the same clinic together, so she saw all of us.
Thank you.
So really good point. In the large academic centers, multidisciplinary care is just a matter of going down the hall. In the community setting, if you're in a urology practice, they are in communication often with their medical oncology teammates that might not be physically at the same location, but in the general area. We'd like to think that. I think that, again, you've seen evidence of how multidisciplinary care can really make a big difference, because there's nuances that might need surgery, that might need a little hit of radiation, and that might need some systemic therapy. And I want to thank you all for an amazing presentation. I hope that you're able to join us for lunch. Thank you all for listening.